a country like Luxembourg, cross-border is really important, right? Because you're really working with all the neighboring countries all the time, and people are traveling non-stop. So whatever use case, you are cross-border in Luxembourg. So how far do you plan to go in terms of the, as far as the Luxembourg eHealth agency is concerned, to try to support semantic interoperability in your country?
We started 8-9 years ago with the Ipsos project, and we've been following everything from Ipsos to ESDSI, MyHealth at EU. Currently, we have patient summary B and A, and we are working on the e-prescription. Of course, it's very important for us because we have people from all surrounding countries coming every day. So it's really, really important. And the work that we've done in these EU projects allow us to have the experience from other countries, to bring our own small experience as well, but also to see what kind of terminology we can use for which use case. And then we build our national strategy first by integrating the experts, because we are not at the agency experts nor enough to know which terminology to use when, how, the translation problems and everything. So we really need the experts, the medical experts, the care experts, and so on. We build a national terminology server as well, which is a bit more than just the terminology server, but also half an ETL, because we need data from so different data source. So it's a bit of everything. So we can build the medication list with the ingredients, the strengths, and so on. And then we wanted to start small and bring value, which means we will not have all the laboratory codes for all exam in microbiology today, that's for sure. But we have 95% of the regular analysis that's easily doable with Long, especially if we work with friends who already did it, and other countries. So that is our idea, to start with a usable data set, not everything, of course, have first feedback, see how we can enhance, and try to, at the same time, bring some additional values at just semantic part. For example, for the laboratories, we worked on the mapping not only for the prescription, but as well with the billing codes. So it's not only semantic interoperability only, it's something a bit more for the laboratory. So it brings something as well. The same for the medication. It's a bit the schema that we saw. All the elements describing the medication, the packagings of the medication, that can be quite helpful to integrate the data directly in the pharmacy, maybe to go as far as pre-ordering medication according to a stock limit and so on. So we try to bring something more than just the coding and on the translations. And we are also having a FIRE strategy now, so we can really have better usage of coded values. It's quite easier with FIRE to have, for example, a longitudinal view of the patient than with CDA. But as it was said, it doesn't mean CDA has not other advantages. And we have also a data lake, a national data lake, so we can have secondary usage and, again, a bit more value on the data that we can have. Okay. So that's our story on
Thank you very much, Samuel. Just maybe you heard the plea from Chantal. Actually, he said, well, they started from their own because they said, well, we can't wait anymore. We really need to do that. We need to support the use case nationally and so on. And we need to provide a road to everybody so that everybody can align itself. We've seen some kind of harmonization taking place in the last decade, so it's a bit less complex. We still have a number of terminologies and so on to map. But are you also today saying to the Commission, it is now time for you to take new initiatives and to build for every country in Europe, a terminology server, not only a master value data set for to support my health, but also a more global terminology server. Is that also your plea?
I would say that any coordinated initiative which takes, of course, into account the needs of every country, every member state, is useful. Does it mean that it's easy and can be done quickly? I'm not sure. But of course, I mean, we saw that we had first Ipsos, then it grows until EHTEL with more and more integrated services. So of course, we can have even more. It's always, I mean, that's why we have the European projects to be able to be consistent on this topic.
Okay, thank you, Samuel. Do you agree with the statements which have been made by Gabor? Is that actually today you still need a huge human investment in order to achieve an actionable result, I would say?
First of all, I think that we need absolutely to go to a learning system. That means that we eliminate human interaction and that the computer learns what things mean. The only way I'm convinced is to go to SNOMED. If every country translates its language to SNOMED, we can have a common language, an Esperanto for medicine, between countries in Europe, but also outside Europe, like China, India, and so on. So I think we have to look further than EU only. We have to look to the whole world. Now, the only way to make it work is post-coordination. SNOMED is there, and the only reason is that you have a full ontology, which means that any detail can be expressed in a coded way, and you can bring codes together to pre-coordinated concepts. Yeah, I will explain it with an example. A classic concept in medicine is acute myocardial infarction. We all know it. It's an infarction of the heart, and there is a SNOMED code for that. Now, you can express that with one code in SNOMED. In ICD, it's only one code. And it depends already if it is ICD-CM or ICD-9 or 10 or 11. But in SNOMED, you have one code for that concept. Now, in SNOMED, you can express, we call that a pre-coordinated concept. Why? Because SNOMED tells that an acute myocardial infarction equals three concepts: an infarction of the heart, the myocardium, in an acute sudden, with an acute sudden onset. The last one is what we call post-coordination. It's like a language. In a language also, we have three words. We have acute, myocardial, and infarction. So SNOMED post-coordinated is actually the same as a language. So if you convert your medical reports to SNOMED codes, you can convert them to any language which is in SNOMED. And I believe that's really, and the same is true for cross-mapping. You go from one code to the post-coordinated SNOMED coding, and from the post-coordinated SNOMED coding to another target code.
How far do you see still the human input needed, the expert input needed? Because that was a very strong statement from Gabor, saying that actually, yes, we can come with very good tools if we have all the resources available. That's even much better. But still, you still need a lot of expertise developed at the healthcare organization level. Would you still agree with that?
Obviously, we always need human in the first step to validate things, but there is so much already coded in hospitals Every hospital is coding ICD-10. In France, it's the ICD-10 WHO, like in the Netherlands. In Belgium, Portugal, and Spain, it's the ICD-10 CM, but it's coded. So you can validate with annotated data, and that eliminates a lot of human work because you use already coded effort in practice.
Maybe Vincent, I would like to ask you, well, as you are an app developer, now you have quite a lot of experience already, and you also try to cope with this issue at some point. So what have you tried to use or to develop with to develop your PHR, and what would you expect either from public authorities or from other third party to support you in your work?
Yeah, so yeah, indeed. Thanks for the question, Luc. So what we did is built a way to store data internally that includes both structured and unstructured data. And we try to take the data as it comes, right, from the various sources. So our PHR is highly connected to electronic health records in hospitals, but also to labs, to devices. And our goal is to collect any health data, whatever the source, right? So I know it's a bit ambitious, and that's for every country also. So it's a bit ambitious, of course. We're not there yet, but our storage system is already compatible with that. And then we have implemented what we believe are the most successful standards today, which are FHIR with low encodification and SNOMED, right? So these are the three basic systems that we use to store, to code the data. And I think this is probably one of the first mobile applications to do that. So it's already pretty innovative, right? But we also recognize that not everybody's ready for that. So we take the data as it comes. So if we receive a lab report in PDF, we store it as PDF until we can get more, right? If we can get in two formats, PDF and some kind of XML with some kind of schema, then we will take both, right? Because one is useful for the user to read, the other one is useful for computing. So that's our approach, to be as generic as possible, taking the best quality data or lowest quality data and use what is available there. Now, of course, we see a huge,
No,
so
go ahead.
what we would like, of course, is, I don't know if I said so, but we also want to be global. So we did that with the US and in Europe. And unfortunately, for us European, I see a huge difference. In the US, our small company, which is a Belgian company, right, European, is compatible with more than 85% of all US hospitals because they are now standardized on FHIR, slowly lowering and SNOMED. It's not perfect yet, but at least on FHIR, right? So suddenly, a small Belgian company can be compatible with 85% of US hospitals. And in Europe, I'm sorry, but it's a real mess. We have a hugely hard time. It's just impossible to have access to a large number of data sets. So what I would recommend is that somehow the European Union tries to impose on all countries and all users of health data that they at some point have a FHIR interface, and then as soon as possible, a standard codification system like lowering and SNOMED. There's others, but I don't think no one will be better than those. So I know it's pretty hard or strict, but I think we are already very late compared to the US, and so that this is what we really need to do and do that fast.
Today, AI actually can support to a large extent also this change of paradigm and the data transformation process. So it would be interesting to know if this is possible and at which condition. So maybe I would like maybe to give back the floor to you, Chantal. Do you, because you are in the Netherlands, also known to try now to develop with MedMay in particular a patient-centered data sharing approach. So, is there any thinking or any plan or any reflection about that, on how could this take place?
We talk about that internally within the company, and it's a subject we tend to touch often, but we haven't reached a definite conclusion on what we should do as an organization, or could do as an organization to promote it better. But it's on our agenda, so
Okay.
who knows?
And Gabor, what would you be your stance on this?
So in the solution that I presented, we do have elements of AI. So for example, for information extraction, always controlled by humans, as I said. So so there are lots of ways to incorporate learning as a one big box to solve all problems. I'm skeptical about it. Primary use, secondary use are not the same constraints, so there's more space for it in secondary use and primary use. But so there's also a very big gap between research and an actual practice, healthcare practice. So if a researcher manages to build a system, an AI system that will work at a precision of 35% instead of 30%, it's a major breakthrough in research, and it's presented at the top conference or journal. But to bring a system of 35% precision to a hospital, I mean, it's out of the question. So, I mean, you cannot even talk about it before 95% or something like that. So, even though there's a lot of progress in research, AI research, I mean, there's a huge gap for it to be applied, at least in patient care. So in medical research, processing existing data, of course there are better advances, and then in non-medical uses, as I said, it's even more possible.
We have to start to prove that we can extract data from the medical record and to make 90% plus exact target code, secondary coding. So that is a validation of your technology, of your terminology. And if you can reach 90% plus for, say, ICD, then you can go further for care.
We are seeing now the need to progress on this issue quickly. The European health data space, which are now emerging as posing additional impetus for this, but clearly there is an investment which is needed from all the actors from the value chain. Those public authorities need to invest money, resources. We know that probably there would be a huge advantage to do a part of it at European level rather than national level. At public level, we see also that we need to find solutions to IPR issues. Of course, that the level of complexity has reduced somewhat over time, and there are solutions now to deal with that in a more agile and flexible way. We also agreed that there is no one fits for all technical solutions, and that indeed skilled human intervention remains compulsory to achieve major quality results. And finally, we might just follow two different paths for different use cases where AI will probably support the data transformation for a number of use cases and with an acceptable level of quality, but for critical use cases such as patient care and primary care, the use of experts will remain necessary. This was the first innovation track webinar this year. We take here the opportunity to thank you very much, to tell you that you are most welcome to join us in EHTEL, which will provide you with a number of opportunities to share your experience within a very dedicated network.